Welcome to a special edition of Biztech's Health and Wellness Show. Today, the conversation is about contract doctors in the public healthcare system who work side by side with their permanent colleagues, but it is claimed that they are significantly disadvantaged in terms of benefits and career advancement. Now, according to the Health Minister, as of May 21st this year, there were 35,000 contract doctors comprising of 23,000 medical officers, 5,000 dental officers, and 7,000 pharmacists. Now, to help us understand the issues from a macro perspective and also from the perspective of the individual doctors, we have with us today Dr. Besima Jamal, who is a former contract doctor with KKM, Dr. Senthil Nadam Subramaniam, who is the Vice President, Malaysian Medical Association, and its section for housemen and medical officers, which is SCOMOS, and Dr. Selina Chew, founder of Medic Footprints. Now, ladies and gentlemen, welcome to the show.
Thank you for having us here.
Now, could we first start by getting each of you to introduce yourself, and we'll start with Dr. Senthil.
Okay, hi Brian, thank you for having me over. My name is Senthil. I'm a general surgeon working still with the government service, working in Hospital Queen Elizabeth in Kota Kinabalu, Sabah. I'm also the vice chairman for SCOMOS, which is the section for civil doctors in the government service under the Malaysian Medical Association. And I've also previously been the specialist in charge of house officers in Hospital Queen Elizabeth for a good 2.5 to 3 years. So, yeah.
So you're very familiar with the issues.
Yep. It's something
now, Selina, how about you? So, I'm sorry?
It's something close to my heart.
Yeah. Selina, could you introduce yourself?
Hi, thanks for having me, Brian. For the second time, really enjoy being here again. I'm Dr. Selina Chew. I'm the founder of Medic Footprints Malaysia. It is a platform where we help doctors, connect doctors with alternative, I won't say alternative, like diverse careers. And we also help them reskill themselves so that they can transition into different fields seamlessly. So we are also very aware of what's really going on. That's why we're here to really help the doctors to find other alternatives if they cannot proceed.
Besima, could you share with us what you do and what you were doing before, which is very important?
Okay, so hi everyone, my name is Dr. Besima Jamal, and I was a former contract medical officer under the Ministry of Health, and currently I'm working as a medical officer still, but under a university hospital setting. So formerly, when I left the service, I was a contract medical officer, which is the current hot topic of the moment.
Okay, now let's start the conversation then with you, Dr. Senthil. Could you frame the problems now currently facing contract doctors in government service?
Okay, I think this is a very heated discussion that goes on various types of medias, especially the social media. To be precise on the exact problems faced by these contract doctors, number one is the inequitable perks and leaves between doctors in the contract service and those in the permanent service, right? To elaborate further, we're talking about unrecorded leave like breastfeeding leave, right? There's also hazard leaves for those who are working in psychiatric departments, or they also call it mental health leave, or radiation leave for those working in radiology departments, right? So for doctors in the contract service who offer the same services as those in the permanent service in these departments, they're not entitled to these leaves. So this inequitable rights is one of the main issues. Secondly, I'm sure you all would have heard the press statement from the minister that says 700 plus doctors have been absorbed to the permanent service in the last 5 years, in the last few years. And there is no clear, transparent criteria as in who gets absorbed to the permanent service, right? We have vague criteria. They call it criteria competency and criteria perundangan. But it doesn't, I mean, if you go by those criteria that are displayed, 50 to 70% of doctors in the contract service would fulfill these criteria. But not all 50 to 70% gets absorbed. So the inavailability of a transparent ranking system is probably problem number 2. Okay. Problem number 3 would be there's no scope for career progression.
What do you mean by no scope for career progression?
Yeah, so basically as doctors, to progress in our careers, one of it is to specialize and become specialists.
Okay.
Right? In the Ministry of Health, to take up certain specialties, you will need a federal scholarship known as Hadiah Latihan Persekutuan. At the moment, that Hadiah Latihan Persekutuan is only made available to those in the permanent positions, right? But talking about specialization using parallel pathways without this federal scholarship, these parallel pathways require a certain number of years of service, right? Say, for example, if you're doing, you want to become a physician, you're doing an MRCP, you will need 4 years of service as a medical officer in the Department of Medicine. But the current contract system doesn't make available that duration of 4 years as a medical officer for those doctors, because the contract ends after a maximum of 3 years of medical officership. So that is also problem number 3. And problem number 4 is the frustration and anger that has been pent up over the last 5 years, a delay in providing an exit strategy plan for the doctors in the contract service. And lastly, I would say the contract doctors being stretched, overworked, burnt out, pushed to the edge. This is something that I think affects all doctors on the whole during this pandemic. And contract doctors being 60 to 70% of the front lines during this pandemic, I'm sure they're equally affected as well. So these are basically the problems that face them today.
Okay, there's quite a number of that. Does Dr. Basima, Dr. Selina, would you like to add to that?
Yeah, I think Dr. Senthil has pretty much covered everything. I mean, especially the part where there is a lot of burnout, I think nothing is worse than the uncertainty of their future. You know, at least if they know for a fact, okay, after this, there's nothing else I can do, at least they can plan for their future. Now it's like everything is up in the air. So when everything's up in the air, how do you make plans? So I guess that's one of the biggest frustrations of all these contract doctors right now.
Okay, now can I ask, how did this, let's take a step back a little bit. How did this parallel system come about? And when did it start?
Okay,
yeah,
so basically, this is a problem that has been brewing for quite some time, right? Let's go back from the start. How did we end up here today?
Yeah.
Right. 15 to 20 years ago, we had very few medical schools in Malaysia, right? In the last 20 years, 15 to 20 years, we've had close to 30 new medical schools in Malaysia, medical, dental, for that matter. And the sprouting of these medical schools over the last few years has definitely increased the number of graduates that's produced, right? Yes. So now we see more and more doctors being produced. Like over the years, from 3,000, 4,000, 5,000, now close to 6,000, 7,000 doctors per year are being produced. And what happens to these doctors? They all apply. Previously, many years ago, supply was always lesser than the demand for doctors in the civil service, especially, okay. Right? And most of them were given permanent posts immediately upon graduation after a few months, right? As more and more graduates started to increase, the waiting time started to increase as well. So they were only absorbed into the permanent post after 6 months, 8 months, and even it went up to about 14 months at one point. And in 2016, the government then decided that one of the ways they can reduce the waiting time was by bringing in the contract system. It was emulated from other developed nations who practice this contract system as well. And they brought the system in for 2 reasons. One was to reduce the waiting time. And secondly was to make it easier to terminate the bad apples in the system. Right, under the permanent system, it's very difficult to terminate a person, especially the bad apples. The process of terminating is a very long and tedious one. Right, so these people will be occupying that post and not allowing another doctor to take up that post. So these were the 2 main reasons the contract system was brought in. And the system is definitely has been proven worthy in other countries. But when we emulate it, I think we need to emulate it as a whole.
Okay. Now, I want to ask Dr. Basima this. Dr. Basima, you left the government service. You left as a contract doctor. Can you tell us how this impacts contract doctors on an individual basis with people like yourself?
So on a personal level, the biggest reason that I left was because of the insecurity. You can't plan your life at all. At the time that I left, I was pregnant. I was going to have a child, but I couldn't plan where I was going to stay. I didn't know where I was going to be after 2 years. I couldn't even buy a house. I couldn't tell my parents where I'm going to be in the next 2 years. And having that uncertainty looming over every aspect of your life, because this is your livelihood, it's really frightening. And especially when you have a family who depend on you, on your income, it's not something that you can deal with day to day. And I think that's one of the biggest reasons a lot of contract officers are pushing for a change for this, because there is no, after your contract is ended, there is no recourse for that. You cannot reapply, for example, to enter the system. I think that's the biggest flaw in the contract system at the moment as well. Once your contract ends, you cannot appeal, you cannot reapply to work in government service. Basically, your only option is to find other ways to work outside of government service. And many still actually want to serve. I love being in the Ministry of Health. I love working in the government service, but I couldn't stay there any longer for my own sake and for my family's sake.
And Selena, maybe you can give us some insights into, because this is your area of specialty, the mental health issues that perhaps plague doctors when they're facing this sort of situation.
Yeah, of course. I mean, like what Basima mentioned and what Dr. Senthil has mentioned, that you just cannot plan. I think the worst thing is the uncertainty, because the unknown is like the most agonizing thing anyone can have to go through, right? Because as long as you know that, okay, let's say I was a permanent staff, so I know that I always had a job. Even if I moved, I knew in advance like where I was going. There's some sort of planning. But for these guys, there's no planning at all. They just don't know what's going to happen. So there's a lot of emotional burnout. Like you're just waiting, like what's going to happen next. And that's how you just, don't just burn out from work. You're just burn out from the uncertainties itself. So that's the biggest challenge, I think, for a lot of the contract doctors, the frustration, the burnout, the anger, like what do they do next? So that's why they don't know what to do. And for us, actually, at Medic Footprints, I've been getting so many emails, and most of them are just lost, because what else can they do? There's no clear path from the government, and there's nothing else here that really caters to help them. And so that's why we are here, and hopefully we can be that platform to support all these doctors. Transitioning is not just about transitioning, it's so much more. It's your identity as a doctor. When you transition, like Basima, she loves serving in the government. Like for me as well, I love being a doctor, but then when you transition to something else non-clinical, so you don't see patients anymore, there's a lot of internal conflict that you have to face. And who do you talk to, right? And the stigma, people will say, you're a doctor, how come you're not treating patients? So there's so much that's actually going on under the surface that is not addressed. So when you say, oh yeah, you can find a job elsewhere, it's not just find a job elsewhere. It's a lot to do with what's inside, how do you deal with all this that brews inside? So I think that's one of the things that are not really addressed. It's not so much of, you can find another job.
Okay, so Senthil, you brought up a very important point, because this is a bigger issue in terms of the impact that this has on doctors from a career standpoint. And I caught the point that you made, that in order to do your specialization, you need to do a minimum of 4 years in government service. But then they only give you a 3-year contract, which means therefore, if I'm a doctor, I'm a contract doctor, basically my path to specialization is cut. Is my understanding correct?
Yep, you're very right. Some specialization requires 4 years, some requires 6 years, but they require you to be in an institution with a specialist, so you're monitored, you have enough exposure to complete your logbooks and all.
So in other words, even if you're a top student, you're a great doctor, you have great bedside manner, you are great with patients, 3 years and you're up, you have no right of recourse.
At the moment, sadly, yes. So there is no room for renewal of contract at the moment.
Okay.
And we are yet to hear about the exit strategy plan for this contract, 5-year contract.
Okay.
So they have, if they finish their housemanship on time, which is 2 years, then at max, they'll have 3 years of medical officership. And what happened next, I'm also waiting to find out.
Okay. So essentially, they are in limbo land. So if you want to be, and one of the challenges is also is there a parallel path in the private sector that they can then pursue specialization?
Okay, so there is other manners in which they can become a specialist. Say, for example, they can be day scholars. It means they pay for their own specialization. Okay. So one of it is once you leave the government service, right, you join the university as a postgraduate student on your own accord as a private scholar, right? Okay. So you pay for yourself. You are not getting paid during that period of your studies. For the 4 years, you don't have a pay, which is ongoing. Okay. And you pay for your semesters and your exam fee for yourself. Okay. And then you may, once you pass out as a specialist, you will then need to be gazetted, right? Gazettement can only be done under the Ministry of Health, right? So then on, if you apply to the Ministry of Health as a specialist, then they may consider you, consider a permanent post or a contract as a specialist. Okay. So that's one way, but not everybody can afford it.
Yeah, not everyone can afford it. And the reality is, because of the sheer supply that's coming in, there's also, this is also a dilemma that's facing the government. So, because one of the key things is we've got to look at the broader picture. If we look at it, and perhaps now let's zoom out a little bit and look at the macro issues, as you mentioned, of the healthcare system itself in Malaysia as a whole. We have too many doctors, as you pointed out at the start of the show, because we have too many medical schools that are turning out doctors, which then the healthcare system as a whole cannot absorb. Am I correct?
Yep.
Okay, but then the fact that contract doctors cannot then become specialists, or the path to them is truncated, doesn't that impact the healthcare system also? Because while we may have a lot of doctors, we actually don't have enough specialists in Malaysia. Am I correct?
Yep. So very rightly said, Brian. So basically, do we have, okay, there's two ways of looking at this. One is the statement that we have too many doctors. Do we really have too many doctors? That's the next question that we need to look at. If we have too many doctors, why is there still burnout amongst the doctors, right? If there was that many people, then there shouldn't be burnout.
True, so that's a good point.
Is it a point that we have too many doctors, but they are mal-distributed? That's something we need to look at as well. Right, impact on the healthcare system due to this inavailability of career progression, right? We will see the effects not today, but we will see the effects maybe in 10 years or 15 years time from now. All these junior doctors can't specialize, and the senior ones will probably go to private, will probably retire or probably pass on. So we'll have less and less specialists in 10 to 15 years. And in time to come, who's going to be treating you and me when we are 70, yes, right? And WHO also talks about universal health coverage, right? Equal access to healthcare, meaning the same healthcare that's available in the cities should be available in the outskirts. But with dwindling number of specialists in the next 10 years, I don't think that's going to be possible. And that's definitely not moving towards a developed nation. So this is something that is serious that we need to tackle now so we don't suffer in 10 years.
Now, I just want to address our audience right now. If you want to ask any questions, or please ask your question on Facebook, and we will ask the panelists and get an answer for you. Now, I want to talk about get some insights perhaps from Selina and from Besima in terms of what your thoughts are, what your experiences are like, because Central, I want to pick up on the fact that there's maldistribution of resources. So in other words, Besima, what was your workload like in your various postings?
For me, I did my housemanship in a district hospital in Johor, and then I did my MO-ship or medical officer in a tertiary hospital in Sabah. So my experience was very different. And in a district hospital where you have, you don't have subspecialties, you have limited specialists. Like the saying there's too many doctors does not apply at all. We used to have maybe 4 doctors to a ward. This is when I was a houseman, covering around 60 patients, some of them overflowing into the corridors. And this was pre-pandemic, mind you. And in a pandemic situation right now, you can see the workload is much, much higher. And I think the problem of maldistribution really came home when I came back to Sabah to serve. Like in the rural areas, especially when I have friends working in primary care and primary health clinics, clinic desa, there's sometimes only one medical officer covering rural populations, maybe few hundred people, and they cannot take leave because they are the only medical officers serving the area. It's that kind of level of like maldistribution. And if you look at the ratio of doctors serving to the population in Malaysia, we have not reached the level that we should be as a developing nation.
Okay, Selena, what was your experience as a government doctor?
So yeah, I actually agree with Santo about this maldistribution. I don't think it makes sense that there's too many doctors because the population is growing every single year. So how is it that there's too many doctors when the population is growing? We are trying to achieve the correct doctor to patient ratio. So the numbers of doctors need to increase to cope up with the increase in the population. So just a personal story, like when I used to work in Seremban, and then I wanted to transfer back to Klang Valley, and I wanted to go into this one particular hospital. I was really interested in the intensive care unit, and I wanted to work there. So when I asked for transfer at the JKNS, I said I wanted to go to this hospital. What they told me was, it's filled to the brim. There's no way there's no way we can add any more staff there. It's like to the brim. No more doctors can go in. So I relented. I said, okay, fine. So they sent me to another hospital instead, but this hospital has not been built up. So I was lucky enough to be to go for an attachment in this initial hospital that I wanted to go to. And I was in the intensive care unit, and I saw it was a skeletal team. They were barely surviving. They were trying to pull MOs from other hospitals like a secondment just to cope with the volume of patients, just to cope with the number of calls and all this. And that's when I realized, like, what does this mean? It just didn't make sense. They're saying that it's to the brink, like you cannot go in anymore. And then now when I'm in there, I was struggling to survive because that's the amount of calls I had to do, the amount of patients that I had to deal with. So it was a complete mismatch. There was just, I think the heads were not talking, and then to the guys on the ground. So nobody really knows what the situation. So that was my personal experience in this whole thing.
Now, within the government, so it's obvious that workload is a big issue, and that's not a Malaysia problem. Even in the NHS in the UK and stuff like that, doctors also work really, really hard. But here we have an issue where the system claims that there's too many doctors from an output perspective. But for you as practitioners, especially now because of COVID and the increased demand for doctors, and this is not going to go away tomorrow. This issue is going to be an issue that continues. Perhaps it's an issue of the fact that it's a budget issue. Do you think, Sento, this is a funding related issue, not a systemic issue of oversupply of doctors?
Okay. Actually, Brian, I think you mentioned now that the workload is increased with the pandemic.
Yeah.
I think the pandemic has just highlighted this problem that has already been there since before the pandemic, right? What Malaysia needs is more health facilities, right? More health facilities to cater healthcare services to the country and our people, as well as to cater more places for training of doctors, as well as specialists. So that would definitely require more manpower, human resource, and all this requires funding, right? In the recent budget, the healthcare budget has been increased by, I think, 7.8%, 2-point-something billion. But that is thanks to COVID, right? But what should be happening is, so what should be happening is the healthcare budget should be growing with the growth and expansion of our healthcare services, right? So our human resource as well, it should be growing annually along parallel to our growth and expansion of our services in the country.
Okay, let me give you some numbers. I think we only spend something like 2%, 2+% of our GDP on healthcare. Somebody like Singapore spends 4%, and I think the WHO standard if I'm not mistaken, and please correct me if I'm wrong, is around 4%. I think that's a recommended number. So relatively, we are at the moment, just from a macro perspective, from a top line number perspective, we are underspending on healthcare. And then that doesn't take into account, besides all the COVID issues, the fact that we are actually an aging population. And we have a population that is a medical community that is actually short of specialists. I think that's the bigger issue that is hidden at the moment, that, as you said, will manifest itself in 10 to 15 years. So my question to the three of you is, what could you then suggest? So we've identified all the issues. What are some of the solutions that we can perhaps propose to the government that will solve a couple of things? One, the short-term issues with these current doctors who basically don't have enough experience to qualify for specialization. Secondly, then, longer-term issues also in terms of these doctors. The third thing also then is the issue from a supply standpoint, the training of doctors in the medical schools. Can I have some insights into what each of you thinks?
Okay, so actually, like what Senthil brought up also was really good. I think that the contract system needs to be a little more fair. The contract system is actually not just the medical doctors. Actually, it's a government thing. Even there's the research assistants or any other post. Some of the other posts, they have the contract system, and these guys are not allowed to apply for loans. They don't like, you can't use like payslip to say that, okay, I can apply for loans. They don't have EPF. So these are
really.
They don't have EPF. They don't have any of the benefits of a permanent staff.
So I'm a bit surprised. How does the government get away with not giving EPF?
They don't have a lot of the benefits of a full-time staff. So I mean,
the contract doctors are not on the pension scheme, but yes, because their contract, they have SOCSO and EPF.
Oh, they do have SOCSO and EPF. Okay.
Okay, so for the doctors they have, but they have also the ones that there are also other contract staff. Yeah, they actually kind of adopt a lot of the non-benefits that come with this. So a lot of the doctors, they don't get a lot of all this benefits like maternity, breastfeeding, and all this other stuff, right? So I think it would be a better system if they actually allow the contract doctors, even though they're on contract, to also get all these other benefits. And actually, honestly, the contract system would be more, it would be more effective if everyone was on contract, even the existing ones were on contract. Then only it would be fair. Then the bad apples can, they can remove the bad apples. Because right now, the bad apples are still there as permanent staff. So the ones that are really good, they just don't get the chance now. So that's actually the best option, really.
Selina, so as a citizen, so this is actually, and Santin and Besima, that's actually, I agree with Selina. As a citizen, what we would like is the best quality of healthcare. So if we have a big pipeline of doctors, we really need to retain with each batch, really, only the really good doctors, to give the opportunity then for doctors to come in to then fill the system and get rid of the bad apples. From your experience, do you all agree with Selina?
Yeah, partly agree with her. So one of the real upsides of the contract system is if everybody was on a contract system, then they will only be rehired on a merit basis, right? Yes. So that way, everybody will aspire to do more, and they will progress. I mean, they will professionally develop themselves.
Yes.
Right. That's a way to go. But then again, the contract system in Malaysia needs to be altered to ensure that there are specialization pathways for those under the contract system. At the moment, that is not available.
Yes, so, and I see that as a very glaring error, because as you pointed out, that's going to be a problem in 10 years, 15 years from now. And you can't solve a problem like that overnight. It takes years to train as a specialist.
If you ask me how to solve it in the nearest short term, I would say there's a lot of tension on the ground at the moment, right? With regards to contract doctor issues. One of it is to harmonize the perks between all permanent and contract doctors, right? By doing this simple harmonization, a lot of this tension will be resolved, number one. Number two, I think, is to allow the contract doctors to apply for the federal scholarship, which is the Hadiah Latihan Persekutuan,
okay,
to further specialize, right? And if they are successful, they should be given a contract for that period of specialization and gazettement as required.
Okay.
Yeah, so these are possibilities that we can look into, and these are solutions that MMA has always been suggesting to the policymakers. And one other option is, of course, it would be best if everybody could be absorbed in with permanent with EPF, permanent with pension for job security wise. But looking at it, is it economically sustainable?
No, and as a citizen,
yeah, and as Selina rightly mentioned, will only the cream of the crop be absorbed into the system? Correct.
Because as a citizen, we've seen the dangers of that happening in other countries where you have a bloated healthcare system or civil service, which then cannot be managed down. Greece is a classic example of that. So we don't want that issue. If we keep the cream of the crop, you will have a steady pipeline of places available every year for new doctors to come in, enthusiastic, willing to serve the nation, willing to serve patients. And the people who are perhaps not so enthusiastic, well, they have alternative career paths that they can leave the service. So I think that,
I just wanted to add a point that to make all that happen, like what Selina mentioned, what Dr. Santa mentioned as well, the key point for me as a former contract medical officer is transparency in the system. Okay. So like we want it to be a merit-based system. Like they say that it is a merit-based system, but there's no transparency at all in terms of ranking, in terms of how they decide who is going to be absorbed as permanent, who is going to be absorbed, who is going to continue as contract, who is terminated. And because of that lack of transparency, a lot of people get very frustrated because they have the numbers, they have the papers to prove that they are pursuing specialization, but yet they are still sidelined. So if there is no transparency in the system, even if we change it to everyone being in contract and the cream of the crop, now, in quote marks, being absorbed, how do we really know they're really cream of the crop?
Now, so here's the thing. I've got a question from Carol May Chong, and I'm going to read it verbatim, okay? During the first major COVID outbreak in Sabah last year, after the elections, the contract doctors were the ones deployed against their will. No permanent doctors were asked to go. Only after a while, and she puts in brackets much later, some but very few permanent MOs went to Sabah, and then she puts air quotes on volunteer basis. Is that really the case? Is that your experience as well? The contract doctors, what she's alluding to is the fact that the contract doctors really get a raw deal.
Okay, Basima, do you want to explain first?
I didn't have that experience, fortunately, of being deployed against my will, but I would say that as a contract officer, you feel like you don't have an option of refusing any order because you feel like it might jeopardize your chances of getting absorbed as permanent. There's that kind of feeling of almost like emotional blackmail. Right? Yes, like
you're basically living with that anxiety
exactly
all the time.
Exactly. So you do anything to improve your chances to become a permanent officer, including being deployed against your will. So I wouldn't know about that exact situation, but I'd say as a former contract medical officer, that was the kind of anxiety that we were working with. Dr. Senthil, you want to add on more about that?
There's always two sides to a coin, right? Let's look at the system now. So over the last 5 years, everybody has been hired in a contract system, right? So the junior MOs, right, medical officers, for the last 3 years have been on the contract system. So in every department, if you look at it, the junior most medical officers are always from the contract system.
Okay.
And the permanent doctors are of at least 3 years experience or more, right? So look at it from an administrative point of view. When COVID hit Sabah, right? Both of us were from Sabah, myself and Basima.
Okay.
So when COVID hit Sabah, it was the third wave and it was in crazy numbers, right? We needed a lot of manpower. And at the same time, services had to run. We did not shut down services, meaning if you had a ruptured appendix, you still needed to get your appendicectomy done. Surgical services, medical services, anesthesia services, all the services were running side by side along with battling COVID, right? So when all these services need to run, and you ask all these departments to let go some of their doctors to help out with COVID, naturally, the ones who are the junior most in the department are the ones who would be probably providing the least services in terms of specialized services, means because the experience is low, yes. Right? Maybe if you're a one-year medical officer, you won't be able to do an appendicectomy, for example, right? So that's probably also why these doctors were deployed first. And as the demands increased, the more and more permanent doctors were deployed later. This is probably the other side of the administrative point of view to what happened during the third wave.
Actually, I just want to add on, I actually agree with Dr. Senthil because back then when I was a permanent staff as well, as a junior doctor, I always get deployed to other places first, you know, so the junior ones will always get sent out because you can't really run the department. So if you send out the senior ones, who's going to run the department, yeah.
Right? What's the long-term solution then to this oversupply? So there is a lot of, the graph tells us there's a lot of medical schools, and there are a lot of people who now wait, correct me if I'm wrong, that may have changed because of COVID. But I know that people were waiting for as much as pre-COVID, as long as a year, basically, before they get their call up to do their housemanship. Is that still the case, Senthil, or how is that working out right now?
The waiting time to be called to work is still, it came down to about 6 months at one point, but now it has gone up to about 8 to 10 months recently. Yeah.
Okay, so what are the long-term solutions to this? Is it, I mean, we have this problem, which is basically too many medical schools. Senthil and Selina and Basima, what's the solution for this, for your profession?
Yeah, so I think the sprouting of medical schools over the last 20 years is basically because medical education is a lucrative business, right? So there needs to be an end to this. There was a moratorium in place. This moratorium for new medical schools to be opened in Malaysia has to be extended, right? That's probably one way to curtail reducing the number of new medical schools. Number two, right? We see when more and more medical schools are being opened, the quality seems to drop as the quantity increases. So one way of doing this is
demand and supply thing.
Yeah. So one way of doing this, I think, would be to amend the Medical Act and make it compulsory for every medical school to have their own teaching hospital, right? If you do this, only the big players will be able to survive. The small players will have to close down. Make it compulsory that all medical schools in Malaysia should have their own teaching hospitals. Not only this will create more facilities to provide more healthcare services to the people, also increase more opportunities for doctors to be trained and even those to become to be trained as specialists. So that's one way of dealing with the medical schools in Malaysia.
Now, Krish, we've got a comment from Krish Siva, who says long-term, and I'll just read it verbatim again, long-term, we should put a halt in the intake for doctors for medical schools, absorb the current batch into the system. Perhaps that's kind of radical. I think what you've suggested, Senthil, will basically weed out the weak, keep the strong and the people with high quality. Because if you have a hospital attached or teaching hospital attached to the medical school, you will have that quality of education, both in theory and in practical terms. Now, Basima, Selina, any of your thoughts on this matter?
I did my medical degree in the UK, and one system that they have there is at the end of your final year, when all the medical schools in the UK finish exams, they would rank every medical student in the country, like nationally. Every single medical student, yes.
Wow.
And based on that ranking, you apply to the university hospitals or any hospital, they call them trusts there, that you would like to work in. And also you can apply for which rotation you would like to do, which is different from Malaysia, I understand. But the fact that your ranking basically affects whether you get to go to your first choice or your second choice or your third choice based on how competitive the hospital is or the rotation that you are going into. I think that's something that we could probably emulate, because in the UK, they're using contract system, but it's not like a two-year contract system like we do here.
Okay.
But having a transparent ranking will at least fulfill the terms of meritocracy, that everyone is being, having their jobs, applying to their jobs and getting their jobs based on their merits, basically.
Well, Basima, can you kind of, that's quite an interesting thing. I never knew that existed. But can you tell us then how this actually works in practical terms? Because different medical schools have different standards. So how do you rank everybody accordingly?
So in the UK, they have, I mean, we have a national exam actually. We have pharmacy exam that we have to take, and everyone gets ranked based on that national exam. So
Okay.
even though you have different medical school systems, you have the same national exam and you're ranked based on that. And then when you apply to the hospitals that you wish to apply, they are ranked based on their competitiveness and based on how many people are going to apply to that. So your ranking in the national rank will determine whether you get the first choice hospital that you're applying for. So it makes, I mean, at the beginning, from the beginning, entering into housemanship, you already have a very clear, transparent ranking system. And then further on, the training is very structured. Once you enter into the training system, after your housemanship, which they call foundation training there's a very clear pathway of whether you want to go into medical training, surgical training, anesthesia training. The pathway is very clear up until the way you are specialist, regardless the fact that you are contract on a contract basis.
And how long are the contracts in the UK for?
Sorry?
How long are the contracts in the UK for?
So it's an ongoing contract basis based on where in your training that you are. So when you finish foundation training, you can move on to another trust or another hospital based on what you want to proceed in. So let's say I want to do core medical training. I can apply to another trust and that will cover my core medical training. When I finish that and I want to do my subspecialization, I apply again and that will cover the duration of my training. So it's similar to what Senthil mentioned, extending the contract to cover the duration that is needed to finish your specialty training. That's how it works over there. And I think having a structured pathway is what we need to have as a long-term solution to make sure that we have people in training to become specialists and we have a continuous supply of specialists.
Sounds like the panacea for us, actually.
Perfect system by any means. I mean, the NHS is flawed, but it's something that we can emulate and work on and improve in our country, I think.
And Senthil, what is the MMA doing in terms of proposing solutions to the government?
Okay, this is something that we've been championing for over 5 years. Since day one, when they introduced the contract doctor system, MMA has been on it, and we have been asking, I mean, we've been providing solutions to this entire problem, right? So the exit strategy plan that doesn't exist. So we've always mentioned the same. Number one, try to equalize the rights between the two systems to solve the problem. Number two, provide, allow contract officers to specialize, to get, to apply for the federal scholarship and to do parallel pathways. Number three, give extended contracts, right? Just for those who want to specialize. 2-year contracts doesn't work in Malaysia because our specialization pathway takes at least 4, some even 6, like cardiothoracic and urology are 6. So give extended contracts to those who want to gain more experience and want to progress in their careers, right? We've been fighting for this all along, but we've also been faced by multiple obstacles, I would say. The change in government, not once, but twice, and also the pandemic for the last 18 over months. And now the clock is ticking. The contracts are going to end at the end of the year. And we also realized that the clock is ticking. And now recently you would have seen on our Facebook page and on social media that we've come up with a campaign called the Code Black, right? Code Black is a campaign standing up and showing solidarity, not only for doctors, but for all healthcare workers in the system who are suffering the same contract system problem, right? So this is, the campaign Code Black runs for 12 days from July 1 to July 11th, right? During this period, we want to show our support and strength in numbers. So we encourage everybody, corporates, individuals, public, all healthcare workers, to actually change their social media profile pictures to black and white to show solidarity. And also we have hashtags and placards that we want to hold up and put up pictures and flood social media with this image that we are not alone, but it's half the country that wants this change to take place for the good of the healthcare in the future. And if possible, we would request everybody to wear black on the 12th and continue to work just to show our solidarity in numbers, so that it will turn heads. The policymakers will turn heads, and hopefully we'll be able to solve this problem soon. Right? So I hope everybody here, including Biztech Asia, will turn your logos to monochrome for us.
And I think, Senthil, you will have our support, and I think the vast majority of Malaysians who now understand the issue better after watching this will support you on July the 12th. Selina, Senthil, and Besima, it's been a fascinating conversation. Thank you for taking the time to be on the show.
Thank you for having us.
Thank you, Brian. Thank you, Brian, for having us.
I'm Brian Fernandez, and I've been speaking to Dr. Selina Chu, the founder of Medic Footprints, Dr. Senthil Nathan Subramanian, the Vice President of the MMA and its section for Housemen and Medical Officers SCOMOS, and Dr. Besima Jamal. I'm Brian Fernandez on a special edition of Biztech's Health and Wellness Show on the plight of contract doctors. To stay in touch with information and issues on healthcare, please tune in to the Health and Wellness Show every Thursday at 8 p.m. Please like our Facebook and LinkedIn sites, as well as checking out our website, www.biztech.asia. Thanks for tuning in.